Thank you, Mr. Chairman. Ladies and gentlemen, I believe the vast majority of us is here because we know or we believe that endoscopic spine surgery is the way to go and that the results will be superior to traditional techniques. But we live in times of increased scrutiny and we have to justify what we're doing, and it is important from time to time to stop and see where do we stand in comparison to what's perceived as the gold standard. And I want to acknowledge my collaborators in this project, which is Professor Loy, Drs. Ritten, Komp, and Wegener. Now, when we look at microtubular discectomy, then there is two important papers. One comes out of Holland, was published in the JAMA in 2009, was performed at 7 hospitals, where they compared tubular discectomy to conventional microdiscectomy for sciatica in a randomized controlled trial. And you can see here that I had a very good 1-year follow-up on more than 300 participants that were randomized, and they found no relevant difference in the clinical outcomes between the minimally invasive procedure and the microdiscectomy, but they found more complications in their series. And this is paralleled to somewhat in paper 2010 out of a group in Milano, I believe, at one single center, who started with 240 participants, which were randomized to open discectomy, microdiscectomy, and microtubular discectomy, and they had a follow-up of close to 90%, which is why they have around 70 people in each group. Results were that the advantage of microtubular in their series was no infections, which they had with micro and open, but also they had a higher complication rate. And those are people who did have experience with microtubular discectomy prior to embarking on this project. So when we look what's known about full endoscopic discectomy or full endoscopic disc surgery, and I think the case has been made before that we need to be clear about what we mean really when we use those terms, because there is not always a very clear definition of what endoscopic means. This is a review that was published in the European Spine in 2010, but focusing only on transforaminal endoscopic procedures and including literature only up to 2008, which excludes some of the newer, more important studies, and included older techniques like the in-out technique. So that really didn't help us very much either, because our question was whether full endoscopic disc surgery is as safe as microsurgical standard procedure, as effective, and whether it confers any benefit to the patient beyond the microsurgical procedure. And so we did a database search for modern techniques, as you have heard described in the previous talks, and we wanted studies which specifically controlled against microsurgical standard procedure versus full endoscopic procedure. And this was our search strategy, which we applied to MBase and to PubMed. And we definitely wanted to exclude laser vaporization, as was asked before just in the previous session. And then we would categorize the returned results into randomized controlled trials, controlled studies, retrospective case series, and so on, as you will see. And this is what we found, updated just now as of June 1914. There is 514 references to be found in those two databases which would satisfy the criteria, but only 12 of those are randomized controlled trials and only 15 in addition controlled studies. The vast majority is case series, personal experiences, tubular discectomy, case papers on laparoscopic fusion, review articles, and so on. Now, when we go in to look at these randomized controlled trials and controlled studies, then we would classify them. Do they have a standard technique as a control? Are they really full endoscopic? Do they contain any clinical outcome parameters? And only then we would include them in our review. And you can see only 4 of the RCTs qualified and only 1 single of the controlled studies qualified for analysis with respect to our study question. And this is, I'm not expecting you to read this, but it's to show that we have only 5 papers which would satisfy those quality criteria, and each one of them is on a different entity or in a different spinal region or with a different clinical parameter, so a meta-analysis, a proper meta-analysis was not possible. So what I will do is I will present those individual 5 papers to you and summarize the key results, and then you can come to your own conclusions where we stand. Now, this is a comparison out of Germany, Sebastian Rütten and Martin Komp's group, which have been extremely prolific in performing controlled studies and randomized controlled studies. This is comparing a full endoscopic posterior cervical foraminotomy with an anterior decompression and fusion, but no plating. Fusion was a cage fusion, but no plating. And they randomized 100 patients each, and they found, red is the key differences that you should take from those papers. The operating time was on average 28 versus 68 minutes. They claimed they had significantly less post-operative pain with the endoscopic procedure than with the ACDF, which I think is easy to believe, but the papers don't give the details. And the return to work in those patients was 19 versus 34 days. So in summary, less operating time, faster return to work, and a claim to less post-op pain. Same group, lumbar surgery, either interlaminar or transforaminal approach, depending on their decision, versus a conventional microsurgical microdiscectomy. And again, operating time, 22 versus 43 on average, significantly less pain with the endoscope, but no details were given, no details on pain medication, faster return to work, and I think this is important, fewer complications in the endoscopic group versus the microsurgical group. Paper number 2. Paper number 3, recurrent lumbar disc herniation, and again, comparing full endoscopic interlaminar and transforaminal versus microsurgical revision surgery, same group. Results. Operating time, endoscopic 24 on average versus 58 on microsurgery. Again, a claim, but not substantiated, to significantly less post-op pain, faster return to work, and this should be read, you should see this here, fewer serious complications with endoscopy. Out of International Orthopedics 2009, full endoscopic anterior decompression versus conventional anterior decompression and fusion in cervical disc herniations. So this is transdiscal cervical full endoscopic surgery. Same pattern, less operating time, faster return to work, no difference in clinical outcome parameters. And our 5th paper out of Voridol in Korea, Sang-Ho Lee, actually I think this is yours. And this is comparing, percutaneous endoscopic lumbar discectomy and open lumbar microdiscectomy for recurrent disc herniations. Faster operating time, 46 versus 74 minutes on average, and the maximum hospital stay, 0.9 versus 3.8 hospital days. Beyond that, clinical results, radiological results, pretty much identical. So what is the common finding of those studies? In summarizing, all these studies showed significant improvement in their clinical target parameters until final follow-up, which was 1, respectively 2 years. There was no difference in clinical outcome between the endoscopic and the microsurgical comparison techniques. There was no difference in radiological outcome. The reoperation rates were comparable, even though 2 studies had a tendency which was not statistically significant in favor of microsurgical. And there were shorter operating times with endoscopy. That was persistent in all studies. Now, what is different? What can we learn? What those exemplary papers show us what's the difference between the endoscopic and the microsurgical techniques. There was a tendency towards higher reoperation rates with endoscopic techniques, but that was not statistically significant, even though all of these studies, I think, were adequately powered. They had 200 participants in all 4 RCTs. There were fewer complications with endoscopic techniques in all of those 5 studies, and that was significant in 2 of the studies with regards to the rate of revisions to fusion for persistent low back pain, 1 versus 5 in one of the written papers, and the rates of serious complications, 6 versus 21%. There was, of course, less difficulty swallowing when you compare an endoscopic procedure to a conventional ACDF. There were shorter operating times with endoscopy, and there was less post-operative pain and a shorter hospital stay with endoscopy as compared to microsurgical. Now, there's limitations. This is only 5 eligible studies out of more than 500 that we retrieved. And 4 of these 5 studies originate from the same group of investigators. And all of those surgeons are highly experienced surgeons, and these studies did not reflect their learning curves with endoscopy. So what can we say, what can we safely say based on this evidence? Is full endoscopic as safe as microsurgical? In highly experienced hands, yes. Is it as effective as microsurgical? Same answer. Does full endoscopic confer a proven benefit to the patient beyond a respective microsurgical traditional procedure? Well, I guess if you have a really good surgeon who is beyond his learning curve, yes, it does. And there's less pain, there's a shorter hospital stay, and probably in some situations a lower chance of complications or serious complications. But we need to be cautious. This may not be predictive of what some of us can expect when they start doing endoscopy, and I don't think we can generalize these results until we have other randomized controlled trials, which other groups come up with the same results, and during the last 4 years, I haven't seen any more randomized controlled trials coming out. So I thank you for your attention. I was able to make up for a little bit of lost time, and I invite your comments.
Is there anybody to give a comment?
Well, I think that last slide was excellent. You need a highly experienced surgeon to get these results. So the problem is the learning curve. It's an excellent procedure. You can hear all the time surgeons talking about becoming the golden standard. To become the golden standard, you have to have the ability to teach it as well, not to do it. So we have to think about areas where we can make the learning curve easier. And I think to do that, you have to make it sure you don't go one way to do all types of herniation. That's not the easy way, that's the difficult way. The easy way is to get the best approach for the level of the disc herniation. In this way, you can get good outcome and teach it properly and quickly so that learning surgeons can really get a good result out of it and not back and drop it again. Because, I mean, we're having a lot of training courses. Where are these surgeons? This is my question. Where are these surgeons? Thank you.
I couldn't agree more with your comments. And I think there's maybe one additional factor. To perform a percutaneous procedure, and I think Gan Choi pointed this out in his keynote lecture, is even more demanding on the 3-dimensional anatomic understanding than a microsurgical open procedure. So it may be that not everybody is well suited to perform that kind of surgery, and the training must be more difficult. But where are the surgeons? I think endoscopic spine surgery is still somewhat regarded as an outside procedure by the mainstream, and I think it is the goal and it is the purpose of conventions like these to close the gap between the mainstream of spinal surgery, where in fact many MIS procedures are already commonplace and established, but not endoscopy. And for a reason that escapes me, endoscopy is still not a topic when you go to a global spine conference or to one of these conferences. And I think that's where we have to work. And I think the World Congress is an important step towards that. And you're fully aware that we have a cadaver course. I think only time will bring that, but also it's our personal effort. We have to get better at communicating what's possible and what's maybe not so possible. And we have to do more scientifically relevant work to actually demonstrate where the advantages lie. And then I think with time, what you alluded to will happen.
Yeah. Doctors, first where you're from and give a
Dr.
question.
Dara, I practice in the United States, and one of the common things that we are facing with endoscopic spinal surgery is the concept of visualization. And one of the problems that is philosophically facing us is the way that the whole insurance world is looking in the United States is that in somehow the endoscopic visualization is inferior to open visualization, and the coding has reflected that. Can you comment a little bit on how you feel the endoscopic visualizations compares to someone doing, microdiscectomy or just a visualization?
Well, thank you for your comment. I think you're right on the money there. Well, we only have to look at who is more likely to pick up endoscopic spine surgery, an orthopedically trained spinal surgeon or a neurosurgically trained spinal surgeon. And I think you'll find many more orthopedic spine surgeons doing it because during their training, they are immediately familiar with a 2D vision, which currently is the limitation to many of us, because we do knee arthroscopies, hip arthroscopies, and so the step to move into spine is more natural, notwithstanding the fact that many of the world's leading experts are neurosurgeons. But when you look at the broad dispersion of endoscopic spine surgery, that's, I think, has to do with tradition. And then, as I mentioned in my previous comment, the three-dimensional navigation and visualization and the recognition of anatomic structures and a translational effort between a 2D image of a different perspective than you are used to what you're actually supposed to be doing with a burr or with a laser is very difficult. But I think when we look back, and Hans-Jörg Loy has pointed it out in history, within 20, 30 years, technology has really brought us a long way. And I think we're only a few years away from the establishment of very, very good three-dimensional endoscopy, or even like front tip endoscopy, which will remove some of the limitations that you have mentioned. And I think this will be an important threshold for the more broad acceptance of endoscopic spine surgery.
Okay. Dr. Martin Knight?
Very valuable paper. I think that was a beautiful analysis. I would just amplify your last statement and say that those papers were looking largely at discectomy. As you say, technology is improving, and those papers don't really analyze the benefit in the older age groups where conventional surgeons simply won't go. They cast the patients off. What you and I are doing is moving into territory where we can help the older patients over a much wider panoply of pathologies. But of course, that's not reflected in the papers, but that was a very valuable analysis and very useful to us.
I think that's important to point out. Thank you.
Okay, thank you very much. Dr. Christof? You.
Okay.
Sir, while that we have clear mind that endoscopic and minimal discectomy is superior to open discectomy and fusion. But in United States, we have found very, very difficult because the insurance, the company, the government, if you do two-level disc surgery with conventional and fusion, you get 5 times more than do minimal invasive. Furthermore, the hospital, because we do not admit the patient, they don't appreciate our work. My own privilege in one of the very important teaching hospital was limited because my case was not admitted. I operate in the morning and go home in the afternoon, and I'm asking this society and all society, Han is here, to write something on the paper to reflect both the governments and the health society that this is much better economic. Patient goes to work in 2 days, if it's office work, if it is laborer work in 4 to 6 weeks. I have done large number, but not. Thank you.
I got your point, but I think if we go that way, we can spend hours discussing this. But the important key factor is we cannot go out and claim superiority unless we prove it. And today's world is asking for higher levels of evidence than maybe 20 years ago, and that's where our challenge lies. Thank you.